Bismillahirrahmanirrahim. In this series of videos, we are going to discuss the disorders of pigmentation and melanocytes. There are many ways to classify the lesions of the skin. We will discuss two of these. These can be classified into the diseases of the epidermis, and the lesions include ichthyosis, Darius disease, psoriasis, and pemphigus vulgaris. Then there are diseases that are limited to the basement membrane zone, and these include epidermolysis bullosa, bullous pemphigoid, dermatitis herpetiformis, erythema multiforme, systemic lupus erythematosus, and lichen planus. This classification is on the basis of the site of the skin that is involved. Then there is inflammatory diseases of the superficial and deep vascular bed, and among these urticaria and angioedema, cutaneous necrotizing vasculitis, allergic contact dermatitis, granulomatous dermatitis, sarcoidosis, and granuloma annulare. Then another head is scleroderma, that is the disorder of the dermal connective tissue. The inflammatory disorders of the panicles are erythema nodosum and erythema induratum, while the acne vulgaris is the inflammatory lesion of the appendages of the skin. The infection and infestations that are peculiar to this area are impetigo, superficial and deep fungal infections, viral infections, and arthropod infestations. While the neoplasm of the skin, the primary neoplasm of the skin, are common acquired melanocytic nevus, dysplastic nevus, melanocytic dysplasia, malignant melanoma, benign tumor of the melanocytes, verrucai, keratosis, basal cell carcinoma, squamous cell carcinoma, Merkel cell carcinoma. There are varieties of adnexal tumor that occur in the skin, fibrohistiocytic tumor, mycosis fungoides, and HIV infection. Then there are some paraneoplastic syndromes that involve the skin. Another way to classify the lesions of the skin is the disorder of epidermal maturation, that is ichthyosis. Acute inflammatory dermatosis include urticaria, acute eczematous dermatitis, and erythema multiforme, while the chronic inflammatory dermatosis include psoriasis, seborrheic dermatitis, and lichen planus. The blistering disorders or bullous diseases can be divided into inflammatory and non-inflammatory lesions, and the inflammatory one are pemphigus, bullous pemphigoid, and dermatitis herpetiformis, while the epidermolysis bullosa and porphyria are non-inflammatory blistering disorders. The disorders of epidermal appendages are acne vulgaris and rosacea, while the paniculitis uh, uh, includes erythema nodosum and induratum and other types of the paniculitis. The disorder of the pigmentation and melanocytes are freckles, aphilis, lentigo, melanocytic nevus, dysplastic nevus, and melanoma. Benign epithelial tumor are seborrheic keratosis, acanthosis nigricans, fibroepithelial polyp, epithelial or follicular inclusion cyst, adnexal or appendageous tumor. Pre-malignant and malignant epidermal tumors include actinic keratosis, squamous cell carcinoma, basal cell carcinoma, or rodent ulcer. Tumor of the dermis include benign fibrous histiocytoma, that are also named as dermatofibroma or dermatofibrosarcoma protuberans. The tumors of the cellular migrant to the skin are mycosis fungoides, that is cutaneous T-cell lymphoma, and mastocytosis. So the melanocytes are derived from the neural crest, and after derivation from the neural crest during migration, they localize into the epithelia, especially the basal layer of the epithelia, and also they are present in other sites. They have got dendritic nature, so these dendrites extend in all directions on H&E stain, however, this dendritic nature is not evident. They have got elongated or wide nuclei, and these have got clear spaces around the nucleus, and the size is smaller than the basal keratinocyte. The tonofilament and desmosomes are absent. However, they are attached to the basement membrane through laminin 5, and the melanocytes that are closer to the basal lamina, they are they have got structures that resemble hemidesmosomes of the basal keratinocytes. This picture, this photomicrograph of the skin is showing that in the basal layer there are some cells with ovoid nuclei, and around these there is clear space. These are the melanocytes. Besides the basal layer of the epidermis, the other site that show these melanocytes are the middle layer of the eye, the uvea, the inner ear, vaginal epithelium, meninges, bone, and heart. The melanocyte produce and secrete melanin, and this melanin can be pheomelanin or eumelanin. The pheomelanin is red, while the eumelanin is yellow-black in color. The function of this melanin, the most important function, is the protection against the injurious effect of non-ionizing radiation of ultraviolet light. Then the synthesis of this melanin occurs within the melanosomes. These are the lysosome associated organelles, intracellular organelles, and the metabolic process of this melanin occurs through the tyrosinase enzyme that utilizes tyrosine as a substrate, and it is a catabolic enzyme. The melanosomes are membrane limited vesicle, and they are located in close association with the Golgi associated endoplasmic reticulum. The maturation of these melanosomes undergoes 4 stages. Stage 1, these melanocytes are round without any melanin, and these are also seen in balloon cell melanoma in pathologic process. Stage 2 melanosomes have got melanin deposit that starts. Then stage 3, there is prominent melanin deposit, while in stage 4 the melanin is fully packed within these melanosomes. The stage 2 to 4 melanosomes are ellipsoid in appearance with multiple longitudinal filaments. The products of the melanin, that is melanocyte product, that is melanin, and these melanin are donated to the adjacent basal keratinocytes and hair follicular cells. They are in close approximation with the melanocytic dendrites, and the end result happens when these melanin pigments are phagocytosed by the keratinocytes, the basal keratinocytes, and this process is termed as pigment donation. Now the ratio of the melanocyte to the basal keratinocyte is 4 to 10. There is one melanocyte per 4 to 10 basal keratinocyte, and this ratio is altered in a condition that is termed as lentigo maligna type melanoma. In this type, this is disturbed. Then the color of the skin. The determinant of the color of the skin is the presence of number and size of the melanosome that are present in the keratinocyte and in the melanocytes, and not on the number of the melanocytes. So these are the melanosomes number and size that is responsible for the color of the skin of the various ethnic groups. As the age advances, the cell number decreases and the people become lighter colored skin, and due to this lighter colored skin and decreased protective effect of these melanin, there is increased risk of cancer. Then the staining process for this Mason-Fontana silver stain, as the melanin is both argentaphene and argyrophilic. So the stain that is used is Fontana Mason or Mason Fontana silver stain, and in addition, the melanocyte and their dendritic processes are identified by Doppler reaction in the histological slide prepared through frozen section, and in the paraffin embedded section, these are also identified by immunohistochemistry of the marker is S100 protein, and this marker is highly sensitive for this melanocyte, but it is non-specific because it is present in Langerhans cell, Schwann cell, eccrine and apocrine gland cells also. Another marker is melanin A or MART1, that is melanoma antigen recognized by T cell 1. For the identification of the melanocyte, another monoclonal antibody is used, that is melan A or MART1, that is melanoma antigen recognized by T cell 1. This is a melanocytic differentiation marker, and it is expressed in normal melanocyte, common nevi, Spitz nevi, and malignant melanoma. Under normal condition, the melanoma associated antigen, that is HMB45, does not react with adult melanocyte. It is expressed in embryonic melanocytes, hair bulb melanocyte, and activated melanocyte. It is usually seen reacting with most melanoma cells, Spitz nevi, the junctional component of common nevi, and dysplastic nevi. The vitiligo is a condition that is associated with the absence or significant decrease in the number of the melanocyte, while the albinism is the defect in the synthesis of the melanin. The hyperplasia of the melanocyte is also a condition, and it is marked in various biopsies, and it is seen in lentigo, benign and malignant melanocytic neoplasm, and as a reaction pattern in variety of neoplastic and non-neoplastic conditions such as dermatofibroma. In a freckle, there is increased pigment donation to the adjacent keratinocytes rather than the melanocytic hyperplasia. Now look at this picture that is showing a melanocyte that is located in the basal layer of the epidermis, and there is presence of melanosome also. And recall in your mind what we have just discussed about the process and various salient feature of the melanocytes and melanization. The disorders of the pigmentation and melanocytes can be studied in certain heads, and these are freckles or aphilis, lentigo, melanocytic nevus, that is also termed as pigmented nevus, and mole, then dysplastic nevi, and melanoma. Then there is condition that is associated with loss of pigmentation, and that is termed as albinism. The disorders of pigmentation can occur as a manifestation of the systemic disorder, and one example is Addison's disease.